Hello, everybody, and welcome to another episode of the Serdentity podcast. I am your hostess, Elizabeth Dewar Anthony, and today I have with me, all the way from Down Under, Dr. David McIntosh, author of Snore to Death, which, this silly filter, but look how your face just,
It's just about
that's
me. It's
awesome.
all about me.
Snore to Death. You're an ENT, you're a physician, and you're a pretty well-known name in the airway myofunctional world. So I'm thrilled to have you with me today. And I have been talking about dental fear for 20 plus years. That's what Serdentity is about, serene dentistry. It's about practicing dentistry that doesn't traumatize patients. And it wasn't until I became a myofunctional therapist that I understood. I always knew there was a PTSD component, but it wasn't until I became a myofunctional therapist that I realized, oh, it's the airway. People are traumatized because they can't breathe. And what I've been trying to get across to my fellow professionals is you can be proactive in assessing and recognizing these airway compromised patients so that when their behaviors come up, it's not a surprise and it doesn't turn into a power struggle.
Yeah.
That's what I see creating the most suffering is, patients reacting, and then the professional reacts to the patient, and then, it's a power struggle, and it just doesn't end well for anybody.
Yeah.
So
yeah.
That's really what, and Serdentity is, ultimately I'm the one who's in charge of my attitude. And if I can change my attitude and approach these difficult patients with non-judgment and a calm demeanor, things are going to go a whole lot better.
That makes sense.
Right? And this has been my lived experience for 20 years. And I've been out there, trying to get the word out there. And the Facebook post of mine that you responded to, I was just feeling sorry for myself because I'm not famous, but it's all right. I'm famous in my own mind.
That's all that matters.
So
being famous is highly overrated. I mean, you don't get to enjoy the normal life experiences of everyone else. So,
right. So let's talk first about PTSD and airway and that kind of stuff. What's your background with that?
All right. Well, let's create a scenario, because that's probably going to be a nice working point. So let me sort of use this as a way of walking through this journey. So our starting point, and it's actually, as I come around to this, it's actually going to be quite evident this actually isn't our starting point, but I'm going to nominate this as our starting point. And the starting point is a parent is bringing a child in for their first dental visit, their first one, okay? Mm-hmm. And the child pops up on the chair, and it's a new person, and they want to have a look inside the mouth. Now, no one's ever done that before. So already we've got a few interesting things. We're in a new place with a new person doing a new thing. Okay.
Yep.
So we've got that on the table, and the child doesn't necessarily comprehend or understand what this is all about because they're a child.
Right.
At the end of the day, they're a child.
Yep.
And it doesn't matter how much, most parents want to think that they can talk their child into things. I have a saying, it's easier to negotiate with a terrorist than a child. The simple reason being that a terrorist knows what they want.
Right.
At least the terrorist has got an agenda there. So you got the child there, and you do what you would think is pretty basic stuff. You say, look, we're going to open up your mouth, and you put like a mirror or something in there, and then the child starts gagging and choking. Okay.
Mm-hmm.
And then they can't sort of keep their tongue still, and they are having sort of, one of their moments where they're a little bit tired and they're a little bit cranky, and the mum has sort of piped up and said, oh yeah, they're prone to being anxious.
Mm-hmm.
All right. So that's our child in front of us, and you're sitting there, you know, first touch point in dentistry, and you're just going, oh my gosh, here's another one.
Mm-hmm.
So let's work out backwards a little bit to what we might be seeing. And this isn't always, but let's just look at how this can frame shift a bit.
Sure.
What if this child has something called sleep disordered breathing?
Yep.
Which is a spectrum of airway pathology, anything from mouth breathing to snoring to the big whammy being sort of end stage disease, being obstructive sleep apnea. What does that have an effect on for the child in the scheme of how this then could possibly be interplaying with what you're seeing?
Right.
Well, sleep disordered breathing means this child's not breathing or sleeping properly. So that automatically leads them to being tired and cranky. They
Mm-hmm.
have a short attention span. They are prone to being emotional, and importantly, they're also prone to being anxious.
Yes.
So we have that in the mix as a starting point. Now, the other thing that plays into this is when they don't breathe properly, it's not unusual that they don't feed properly.
Yes.
So children are survival machines.
Mm-hmm.
So in a situation where they cannot breathe properly, but they're obliged to eat and drink in the process of surviving,
Yes.
particularly with the eating side of it, they will have a tendency to gravitate towards stuff that is quick and easy to clear.
Yes.
What that means is soft, mushy stuff.
Mm-hmm.
What that means is that they have not got accustomed to hard things inside their mouth. How does that relate? Well, like I said, you put a mirror or the like inside their mouth and they start choking or gagging. Why do they
Yeah.
do that? Well, because they're not used to firm, solid things in their mouth because they've been avoiding it as part of their feeding pattern.
Yes.
So I use the analogy of, you know, you'll see the sideshow alley trick of the sword swallower, where
Yes.
they'll get a long sword and they'll swallow it and they'll put it all the way down and pull it all the way out.
Mm-hmm.
Now, you don't get to do that by trying that the first time.
Right.
It doesn't work that way. So what do? They slowly train and habituate themselves to suppress their gag reflex so that eventually they can pull off that party trick.
Yep.
And it's the same with growth and development in terms of a child.
Mm-hmm.
So if a child is, you know, and then like I said, children are survival machines. They're not doing it because they're fussy. They're not doing it because they're being difficult. They're doing it because they've worked it out for themselves that chewing on that piece of meat or crunching through that raw carrot or whatever it might be, it's just too much hard work between that and then trying to breathe through their mouth to survive.
Exactly.
So it's kind of like, you know, how long do you hold your head underwater? Well, not for very long because you need to come up for air. And it's the same with
Right.
feeding. So this is the story that we have. So the child has come in and, you know, the parent has brought them in and sat them down and you know, you've done the best you can do and it's just turned into an absolute mess. Now,
Mm-hmm.
how could have we turned that ship around before we hit the rocks? And my premise to this is that I think every dental visit is an opportunity to basically be a sentry or a guardian at the airway. Because at the end of the day, if we look at dentistry and we look at ENT, we're all kidding ourselves if we don't think we're looking at the same anatomy.
Right.
We're clearly in the same ballpark, clearly.
Yes. Yes.
And there's a huge overlap between ENT and dentistry, so much that I've written books and books about it and you know, keep advocating things because a huge mistake was made in healthcare. One of those, well, actually, many huge mistakes. One of those huge mistakes was separating dentistry and medicine. And we do
Yes.
that pretty much from day one at university. The second big mistake that we've made in medicine, particularly, is putting things into silos. So, from
Yep.
a medically trained person, we're very accustomed to just working in our lanes. You know, sort of
Mm-hmm.
the thing. So, you know, so for example, myself as an ENT. So you go, all right, well, that's ears, nose, and throat. Okay, big deal. Well, one of the things I do routinely in children is I do a blood test to check their iron level,
Mm-hmm.
and I get pushback from other medical doctors saying, "Well, hang on, you're an ENT. What place have you got checking iron? You're working out of your scope." I'm going,
Mm-hmm.
no, excuse me. I've got a medical degree.
Yeah.
I've got a surgical training. I've got a PhD, and that translates into having a brain. And that brain's allowed to that brain is allowed to think, and it's allowed to act. And if I come across important information that is relevant to the children that I am looking after, and I am in the process of testing for things and then finding things that have been missed along the way,
Mm-hmm.
how on earth am I subject to criticism for being thorough? But that's the world
Mm-hmm.
that we live in, because
Right.
it's like, oh, that's not your job. And that's what I hear when I sort of bring these things up in dentistry, especially from what I would consider to be the old guard. You know,
Mm-hmm.
it's sort of like, well, that's not part of our training, that's not part of our scope. And I go, well, maybe it wasn't part of your training, but you might want to open your eyes to what's going on in dentistry at large, because airway dentistry, sleep dentistry, and the like are exploding in their numbers, simply because once you see this, you cannot unsee it.
Right.
So,
Exactly.
so,
Exactly.
so how do we spot this at the dental clinic? Well, from my point of view, it actually starts on the intake form.
Mm-hmm.
I think on the intake form, sort of standard common things would be like, from a medical point of view, like, do you have asthma? You go, all right, so why are we asking about that? Well, because some asthma medications can interfere, and it's good to know background health, because asthma is a significant health condition. But the way I angle it is go, well, asthma is related to allergies like hay fever, nose allergies. That's related to airway and breathing.
Mm-hmm.
You know, and all roads lead to airway and breathing. When I look at this, behavior problems, learning problems, and so forth. And if the child is coming in and they've got bags under their eyes, they're tired,
Mm-hmm.
they're cranky, they're anxious, you can see they've got their mouth open. That's your sort of next stepping point. You know, we haven't even got to looking inside the mouth yet. We're looking at the facial profile. This
Mm-hmm.
child looks tired. This child might have, nasal allergy signs. They can have a crease across their nose, or, but, runny nose, or they're sneezing a lot, or they just sound blocked.
Yep.
And then you start going, right, this is interesting. And then you can turn to mum and say, look, just before I even start my exam, I've just got a few things I've spotted straight up. I just want to sort of make sure that what we're walking into here isn't going to be, fueling some issues.
Mm-hmm.
Um, does your little Jessie here, does she like mouth breathe and snore at night and wake up through the night? And if you notice that she's grinding her teeth and she's sleepwalking or sleep talking, and it's kind of like don't poke the bear in the morning kind of kid.
Mm-hmm.
And the parent starts looking at you going, yeah, but isn't that like every 2-year-old? And you
Right.
start to go, right, let's refresh what you think as a parent, because you're conditioned to think like everybody else has been conditioned to think, and that's not your fault. But we made some serious mistakes along the way with kids, and I'm one of those people that wants to fix those mistakes. And then you can explain airway and breathing and so forth and go, look, so I'm going to try my best here. But especially since this is the first visit, there's a really good chance, especially because you've told me they're a fussy eater. They might chew on some meat, but they don't tend to swallow it. They spit it out. We might have a choking gagging problem here, because it's not unusual for the gag reflex to be a bit extra sensitive in this situation.
Sure.
So I just want to just sort of see how we go. And if things are going pear-shaped, well, look, we're better off just backing off rather than pushing forwards.
Mm-hmm.
But one of the outcomes of today is I'm going to be recommending that you see an ENT. And I know that's not what you walked in the door for, and I know that's a little bit left field, but here's some reading material which you've got
Mm-hmm.
pre-prepared,
Yep.
so that you can understand a bit more where I'm coming from. And here's some resources. Here's this dentist that talks about this. Here's this ENT that talks about this a lot. Here's this pediatrician that talks about this a lot. Just so you can sort of know the sort of, background of where I'm coming from what I've observed and learned, because I wasn't taught this in my dental training, but gee, I'm glad I know about it now.
Yeah.
And that way you've changed the dial a bit before you even started. You get the same outcome. The child doesn't cooperate, they choke and gag. But the parent is kind of getting a confirmation bias thing happening here, because you prep them. The
Mm-hmm.
parent's going, oh, wow, this person was right.
Yeah.
Oh, wow, they really are not coping with this. They really are struggling. And it kind of makes sense why that's the case, as opposed to, oh, my God, that lady was so rough with my kid. I'm going to go see someone
Mm-hmm.
else.
Yeah.
Okay.
Yeah.
So that's that. But now I'm going to take an even bigger rewind, because the thing that you didn't necessarily see was, as the parent was driving that child to the dental appointment, was the parent going, now you're probably not going to like this. It's going to be something that you need to sit still for. All
Mm-hmm.
right. And um, don't worry, it's not going to hurt. And
Right.
all these things might sound innocent to a parent, but they actually prime a child. They,
Absolutely.
they actually go,
Absolutely.
if you were taking a child to Disneyland and you said, don't worry, the ride is not going to hurt,
Right.
the child's going to go, well, I didn't think it was, but now that you've said that, why would I worry about that it might?
Right.
You're actually planting seeds. Not it's not deliberate. It's all unconscious, but you're planting seeds. So if you just go in and so forth, with those things, then you're starting behind the background. Now, why did the parents say that? Well, this pernicious thing about sleep disordered breathing is that once you have it as a child, once you start having your own children have a 50% chance of having the same.
Mm-hmm.
So if that parent's lived experience was sleep disordered breathing, which was completely missed and
Yep.
completely ignored,
Yep.
and their lived experience as a consequence that was terrible dental experiences,
Yes.
then moving down the track, that dental experience is then what they then relate to their child. And
Exactly.
because their child has that prepping and priming in the condition of having sleep disorder breathing at the same time,
Mm-hmm.
then you basically, everything is just getting set up to fail from the get-go.
Mm-hmm.
And then that's when, again, you can sort of, before you start with the child, you sort of turn to the parent and go, just out of curiosity, do you reckon that you could have had any of this as a child? Did you have trouble at the dentist, growing up? And if the parent
Mm-hmm.
starts going, oh yeah, that was, this is definitely, I hate going to the dentist, you
Mm-hmm.
know, you start going, okay. And have you noticed that, as yourself as an adult, that you've been getting, holes in your teeth, even though you've been looking after your stuff? You can go, yeah, I have been actually.
Mm-hmm.
And just have a quick look inside mummy's mouth before we have a look. Oh my gosh, look at all those fillings you've got.
Mm-hmm.
So, and it looks like you might be grinding your teeth as well. You're not a snorer or a mouth breather yourself, are you? And then the mum will sort of go, well, yeah. And you sort of go, look, I think there's a bigger picture here. I know you came in for your little Jessie here, but we might need to have a chat about you while we're at it too. And here's a little bit of extra that you just might want to reflect on. But, don't get me wrong. I'm not, this is all about her, but I would hate, again, for you to miss out on all the stuff I know about. And then mum is absolutely baffled and confused and intrigued, all rolled into one.
Yeah.
It's half on the fence as to which way this whole thing is going. It's kind of like, are you trying to do an upsell or something? But there's a lot of what you're saying. And then they can go back and read and go, look, kids that mouth breathe get holes in their teeth, even if their diet and oral hygiene is perfect. Kids with
Mm-hmm.
nasal allergies get that as well. Kids
Yep.
that have sleep disordered breathing, mouth breathing, snoring, sleep apnea, they grind their teeth at night. As part of grinding their teeth at night, another thing that can trigger that is low iron. What leads to low iron? Not eating meat. What leads to that? Not breathing properly. And,
Mm-hmm.
and I just thought they ground their teeth because they were stressed or anxious. And you go, well, why is your 2-year-old stressed and anxious? Like, if they had an
Right.
argument with their boyfriend, or they're having trouble paying their bills at the moment,
Right.
is their boss at work giving them a hard time? Or is their brain going into stress mode because they're not getting enough oxygen?
Right. Suffocating is stressful.
Yeah, apparently so. So all of a sudden, the parent has found somebody that seems to have a very different perspective, but it's been given to them in a constructive way.
Mm-hmm.
And again, we haven't even got to looking at the child yet.
Yep.
We haven't even got to that point, and we go, all right, well, look, we've got enough on the table here. This may or may not go so well. Let's go
Mm-hmm.
have, and then you go, all right, let's do it without putting anything inside the mouth first. Let's see how big can you open your mouth, and let's see how many teeth we can count. And then you start to go, oh my gosh, I can see teeth. And then you just start playing the game as whatever your game is. But
Right.
just for might start to go to, all right, mum, we've actually got some holes in our teeth already. And just so you know, I can see some the teeth are getting ground down. And Okay, now let's try and lift that tongue up. Oh, that tongue doesn't lift up. Hey, mum, did you have trouble with like breastfeeding back in the day? And mum's starting looking at you going, that's on the list too now. And you go, yeah, that's on the list now too.
Mm-hmm.
And then you start looking, you go, all right, did you have orthodontics when you were a kid growing up? And mum goes, well, I was supposed to, but your family couldn't afford it.
Mm-hmm.
Um, and then they start going, can you see that there's problems already? And you start to go, well, that jaw is a little bit of a problem, but let me come back to that one. And did anyone have sort of mentioned those tonsils that I can see at the back? And they go, oh, yeah, the doctors have seen that, but they've said they haven't had tonsillitis, so I don't need to worry about it. And you go, okay, we're going to have a few touch points on what we've just come across, because there's a lot more going on here than what you realize, which I know is not what you walked in the door for.
Mm-hmm.
Um, and wasn't either what I was taught or trained. I didn't know this as a parent growing up. I certainly didn't know this 25 years ago, but I just got lucky one day. 20 years ago, I came across something that changed my life.
Mm-hmm.
And that moment for you as well. And I sort of can't unsee what I've seen now.
Yeah.
I think the child really needs to go and see that ENT that I mentioned. And
Mm-hmm.
you can look from there. And look, that might sound very idealistic and it may not be practical and so forth for everybody to sort of, weigh up and consider and implement into their clinic. And that's okay, except it's really not. Because we know that the most common cause of teeth grinding is not being able to breathe properly at night. We know that 2/3 of children with orthodontic problems have an ENT related airway problem.
Mm-hmm.
We know that having a tongue tie plays in with feeding problems and jaw growth development problems. We
Mm-hmm.
know that mouth breathing contributes to getting holes in your teeth, even if your diet and everything else that goes with it, oral hygiene, etc., is good. And we know that children that don't breathe and sleep properly, it affects their brain growth and development, and it affects the way their heart and their blood vessels and their gut, and pretty much every body organ you want to mention grows and develops.
Right.
So we can't. When you see this, you cannot unsee it,
Yes.
um, unless you choose to then be negligent about it, because that's basically what can then flow on is you sort of choose not to be part of this,
Mm-hmm.
um, and those children get missed, and those children suffer, and they don't need to. And it's not about diagnosing. You're not, people talk about scope. Oh, it's not my scope to diagnose an ENT problem. You didn't diagnose an ENT problem. You flagged concerns that warrant an
Mm-hmm.
opinion. You're not diagnosing, that. You're observing things that make perfect sense and coming to reasonable conclusions. And you're saying to mum or the like, and you're saying, look, I can't be sure about this, but I don't want to be the person that misses a problem here. And there is enough here that I am worried about
Yeah.
that I think getting the ENT to look over things is really worthwhile. And then mum goes, Dad snores a lot.
Mm-hmm.
And I know I mouth breathe all the time. Do you reckon we should see the ENT as well? And you're going, yeah, let's make it a family affair. Let's get you.
Right.
So, look, I know that was a long-winded answer to your question, but that's how I just wanted to sort of just paint it out because, you know, what I know is some people just don't like going to the dentist, but you got to look at why. What happened in
Exactly.
what
Why?
happened what happened in those touch points. And then if you had a bad experience in anything in life, you sort of we have the saying once bitten twice shy. once
Mm-hmm.
once through it once, you're kind of hesitant to do it again.
Right.
And yeah, we know that having sleep disordered breathing increases the chances of having PTSD.
Yes.
If like I mentioned anxiety, but it actually increases every other mental health disorder you want to mention.
Mm-hmm.
So schizophrenia, bipolar affective disorder, psychosis. The list goes on. Why? Because they are manifestations of brain function and development. And
Exactly.
what's wrong with sleep disordered breathing is problems with brain function and development. So, all these things are just circling back on themselves again and again and again. And, getting breathing sorted is kind of important because that also then involves getting sleep sorted. And when we talk about pillars of health, people talk about diet, exercise, and now sleep has sort of, got into the mix.
Yes, it's
And
getting there, thank God.
yeah, and breathing is sort of, nipping at its heels, trying to play catch up. But if you think about, when you're born, what is the very, very first thing you do? It's breathe.
Right.
The first thing you do is take a breath. The second thing, for most things that you're moving on to, you're feeding. And then what do? You fall asleep.
Mm-hmm.
All right. And then as time goes by, you start moving and everything, crawling to walking to running to everything else. But if you think about like just that sort of natural sequence of things, you breathe, you feed, you sleep. That's your first sequence of big picture things that you do. Um, so, that's what nature's trying to tell you. It's just like breathing is important. I can't go without breathing. I
Right.
need feed. I actually need sleep more than I need feeding, though. I can
Mm-hmm.
go without food for a while, but I can't go without sleep for that same period of time. You can starve for 2 or 3 days, but you cannot be sleep deprived for 2 to 3 days. It will not end well. So, from that point of view, just building it all up from there, this is, how these things can make a lot more sense. So, instead of it being the child that just wouldn't cooperate, and it's just like, oh my god, here's, you know, you start thinking, oh gosh, what sort of parenting skills are on the table here?
Yeah.
How it can all sort of be observed and escalate. Where, in actual fact, this parent is struggling like crazy, just to keep this kid on track. And the parent just goes, oh, that's the terrible 2 stage, and the troublesome 3 stage, and the fearsome 4 stage, the effed 5 stage, and the lucky 6 stage, and the stupid 7 stage. Uh, we get to the elegant 8 stage. I've got to wait till then.
Right.
No, you got to get this kid sorted now. And if you're making excuses because society gave you those excuses, don't use the excuses anymore. If there's a problem, get it sorted. And
Mm-hmm.
this is the whole thing. Go watch that child at night. Most parents don't know.
Yeah.
You go, I don't know if they mouth breathe. I don't know if they snore. You go, guess what? We just got some homework. We need to know. Because, long time ago, we all used to sleep in the same cave and then
Right.
eventually the same room. And now, we get our own room to ourselves, as such as the privilege of progress. But it also means that we've separated ourselves in terms of knowing what's going on with our child.
Mm-hmm.
Let's go.
Now,
So, yeah.
how many kids have you seen where if once you got their breathing better and they're sleeping better, they were able to come off like ADHD medications or really kind of come around that way behaviorally?
Yeah, so look, so I guess just to rewind on that. So if we look at the diagnosis of ADHD, it's a criteria-based diagnosis. And those criteria are all spelt out in black and white, and it's a box ticking exercise. So we talk about things such as being able to concentrate, focus, sit still. There's behavioral elements and so forth that all sort of go with this. Now, if we just put that list to the side and completely separately, we make a list of things that a child with sleep disordered breathing has.
Mm-hmm.
And then we look at those two lists. You can pretty much get 2/3 of the ADHD list done straight up for a kid with sleep disordered breathing,
Mm-hmm.
just straight up. So you're already past halfway without even trying, and a few other little bits and pieces, and you're there. So we have basically three conditions. We have ADHD, which is true ADHD.
Mm-hmm.
We have ADHD in a child that also has sleep disordered breathing. So they
Mm-hmm.
have both. And we have ADHD that is a misdiagnosis
Mm.
because they actually have sleep disordered breathing in the first place.
Right.
So there are three groups. So in the ADHD true group where there's no airway problem, well, there's nothing I'm going to do that's going to change that. If there's no airway contribution to it, that's not it. If they've got both, well, addressing the breathing and sleep is important just in its own right.
Mm-hmm.
As to what magnitude of change that may have on the ADHD symptoms is hard to predict ahead of time
Mm-hmm.
because they're blended together. And I don't know, is this a 50-50 blend? Is this a 90-10 blend? I don't know. So I don't know how much better it's going to make things. I just know that getting breathing and sleep better is important, regardless of whether there's ADHD or not. And if in the process the benefit is that the ADHD was only a minor player in the game, well, then we'll get a major response. If the ADHD is a major player in the game, we'll get a minor response.
Yeah.
But it's all positive response. It's all improving things. And if that means that for that child that their medication requirements decrease, well, that's a win.
Yeah.
You know, that's a win.
It's
They need
win-win.
less, because we're not fighting against the additional symptoms of sleep disordered breathing that we're trying to medicate when we should have actually been alleviating the. When it comes to the misdiagnosis group, though, that's where we see the huge differences.
Yeah.
But it's important to realize we don't know from the beginning whether this is a misdiagnosis 100. So this is that 100% sleep, 0% ADHD. We don't know. You know, I don't know. Like I said, I don't know if this is a 199 or a 0100. I don't know how this blends until we get it done. So I don't give parents false hope.
Yeah.
You know, I don't say, look, I'm going to fix this and your child's going to be completely better and blah, blah, blah. Because that's not fair to the parent.
No.
And so forth. But what I was going to say, look, I know we're going to make things better. You know, it could be anywhere between a little bit and a lot. And that lot could be everything. And it does happen, you know, and this is what the science backs up, is that if we find these children and we get their airway breathing better, they're learning their behavior, their concentration, their emotional regulation, etc., it all gets better. So from that point of view, I don't focus on, you know, let's make ADHD go away, because again, that's not the game. What I'm doing is let's get the breathing and sleep better, and let's see what that translates to overall with everything else. And you know, the problem we have is, you know, and I published this the other day, and you know, I always enjoy the pushback, because then I basically show the science, and it's amazing how people go quiet all of a sudden when I show them the science, especially when they're proclaimed to be specialists in the field. You know, and I sort of go, you know, ADHD went away in 25 to 50% of kids. What does that mean? It was never ADHD. Surgery, ENT stuff does not make ADHD go away.
Right.
It makes the thing that led to that diagnosis being made go away, which means that if that is the case and those things have gone away, the diagnosis was wrong. That's what it means.
Yeah.
So we know that 25 to 50% of these diagnoses are wrong. And they're just not being assessed from a breathing and sleep point of view. They're just not.
Yes. Yes.
And it doesn't make sense, because when it comes to this thing called sleep disordered breathing, it affects 1 in 5 children. We're talking about something like, if you got kids going into, you know, a school classroom and there's 25 children, 5 of those kids, 5 of them have got this problem, straight up. And of those 5 children, we know that if we're lucky, maybe one of them will get fixed. You know, and realistically, it's half of them, half of one. It's 10%. So, you know, this is how far behind we are. So if I take a sort of a bigger group of numbers, so if you've got 1,000 kids, that's 200 children. We're fixing 20 of them. There's 180 kids in that group that are getting missed. And that's why I want the dental clinics as part of this. And in fact, it's not just the dental clinics. I want the schools part of this. You know, I want the speech language pathology part of this. I want everybody part of this. You know, my pleasure of doing this podcast, I'll, you know, share a fun fact for you. My very first podcast interview ever was a guy that lives in the United Kingdom who was a bus conductor. Okay. And he found me through Facebook, because that's all it was back in the day. And he said, I've just been diagnosed with sleep apnea. I've got a CPAP, and I've read what you've been saying, and I'd like to interview you. I'm going to do this thing called a podcast. What the hell's a podcast? And stuff, and so forth. And I did it. and he was the very first person that interviewed me for a podcast. And I wish I knew where that podcast was, but obviously
Right.
back in the day I didn't have the understanding or whatever. But the world's changed since then. So, and why did I do that? Why did I give up my time and share my knowledge and everything with of all things, a bus conductor? Because he wanted to know.
Yeah.
He wanted to know. And, my premise is, at the end of the day, me spending my time with you like this now, I only need one kid, just one
Yeah.
kid to benefit that was otherwise going to get missed. And that makes it worthwhile.
Yeah.
Because, and I'll never know who that kid was. And I know from experience that it translates into more than one kid, because the thing that changes everything is word of mouth.
Yeah.
As soon as one parent trips over this, it's their job to tell another three. And
Yeah.
out of those three, it's then they're going to pass it on to another three. And then it starts to spiral.
Yeah.
And then all of a sudden we have what we're supposed to have, which is parental awareness,
Yes.
parental education. So that at the end of the day, it's not you having this situation, where you're starting from the beginning. It's the parents coming in and going, all right, um, I had breathing problems as a kid. I was supposed to have orthodontics. I realize I can't breathe properly myself. My kid's
Mhm.
going down the same pathway. I've already checked them at night. They've got their mouth wide open. They snore sometimes. They're grinding their teeth like crazy. Um, Start doing the best you can. I know it's probably going to be a bit of a struggle. And then I need to know which ENT you work with because we need them on the team. Imagine that.
Yeah, it's getting better. Parents are coming to myofunctional therapy consults better prepared, but we still have to do a lot of education.
Yeah.
Talking just like you're talking about the oral facial structure, their breathing, and pointing things out to their parents that the parents just don't know. And it's amazing how kids calm down even with just oral facial myofunctional therapy. Parents call, after like 3 weeks of the kid doing these exercises. Wow, Johnny's really like a different kid. He's sleeping. He's a lot less busy. I mean, what's better than that?
And look, this is the problem is that we all know this. The problem is we do a terrible job getting this out here, and it is a systematic problem. I compare healthcare to the airline industry. So
Yeah.
so with the airline industry, if somebody is flying a you know whatever the current version is, let's say it's an Airbus 380, and there's some sort of unusual malfunction. Well, that pilot reports that, and
Mm-hmm.
that report goes to every single pilot in the world that is licensed to fly that plane. So every pilot gets the heads up about this little problem and what it meant and what was done and what to do about it. Okay.
Mm-hmm.
Now, if a scientist that studies breathing, sleep, and brain growth and development publishes a scientific paper, if we are lucky, and what they discover is groundbreaking, like it's
Yeah.
life changing. If we are lucky, that will start to get recognized in healthcare after 10 years. And it will take potentially up to 30 years before it becomes baseline established. Now, that is woeful.
Yeah.
you know but it's also a reflection of the fact that we have poor information systems. We
Mm-hmm.
have poor information systems from the scientist getting to me as a clinician, because the conduit is putting it in a paper. Now, there are thousands of papers that have just been published between you and me talking just now.
Right.
Okay. And within that, some of them are relevant to me and some of them aren't. But where do I go searching and finding and stuff? I don't, and I miss it. And what does that
Right.
mean? Well, because I missed that big notification, and I continue to miss it, even though it was, it wasn't actually just now, it was actually 5, 6, 10 years ago. I just keep moving forwards thinking I'm doing the right thing.
Yes.
And then some upstart that's read that paper that's doing something completely different looks like they're off in cuckoo land doing something weird and wonderful that I've never heard of. And my
Mm-hmm.
automatic reaction to that is, well, that person's nuts. What on earth are they doing?
Yes.
All right. As
Yes.
opposed to, all right, I haven't come across this. There's two scenarios here. Either I'm behind and this person's way ahead of me, or this person is nuts. So I can either be
Why does
dismissive
it
or
go to the nuts? Why does it always go to the nuts?
because we don't want to be wrong.
Yes.
We don't want to be behind. We want to think, especially someone that sits in my shoes. All right. So look at my shoes. All right. I was in the top of my class at school. Okay. I was in the top 10 of my class at university. I got into surgical training, which is the hardest thing to get into. And I take people's lives into my hands every single day I'm doing surgery.
Mm-hmm.
Okay.
Mm-hmm.
You think there's no you think for a moment there's no ego built into that algorithm? Of
Right.
course there is. All right. And so for someone, like whoever, let's nominate you to come and tell me that there's something about ENT that I don't know about. Okay. I'm gonna
Mm-hmm.
be like, all right, let's just calm the farm, hun. Let's be
Mm-hmm.
realistic. Look at everything I've done. What could you have done that you're right?
Mm-hmm.
That's the reality. Is so what is my reaction? My reaction is I know more than you do because I've done this, and this. And guess what? Maybe you read that paper yesterday that came out hot off the press, and you're
Mm-hmm.
bringing it to my attention now. And I don't
Mm-hmm.
know about it, So when I come across new stuff, I've learned the hard way that fact checked it first. Now, in the process of doing that, sometimes I'll look at it and go, "All right, that's actually is nonsense." But other
Mm-hmm.
times I go, "Right, I need to pay attention to this one." Or it's like, well, it's kind of right, but it's being blown out of proportion. That's
Mm-hmm.
that's that's the filter that I've got for a lot of this stuff. I can sort of look at it, and look, and sometimes I'll go, "Look, this is old news. We've been here and done this before, and
Right.
I've been doing this long enough now. I genuinely think I'm actually getting to grumpy old man stage, because every now and then something will come up and just go, we were talking about this 20 years ago. This is not new.
Yes. Yes. Oh
You
my
know,
God. Everything old is new again.
yeah,
And you were talking about silos in the beginning, and Ignac Semmelweis, the guy who figured out that you should be washing your hands,
yep,
right? Was
yep,
died in an asylum and was
yep,
laughed out of his profession.
yep, yeah,
So this ego, these silos, and this, we really need to take a look at the whole picture. And I'm
yeah,
so happy that there's physicians like you who will listen to dental people like me and actually engage in a conversation rather than thinking, what the, you know, I'm just a dental hygienist. What do I know?
yeah. No, 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 no. So when I finished medical school and started working in the hospitals, I realized there was so much I didn't know. In the first 6 months, it was the nurses that had been doing it for 10, 15, 20 odd years that taught me far more.
Yes.
That was useful and practical than all the book work I did at university.
Yeah, I
So I
love
learned.
nurses.
And then the next thing was basically what I learnt from basically dentists,
Mm-hmm.
because if I hadn't have had that moment, I would have continued on my merry way as an ENT, thinking that all my ENT stuff fixes all the airway stuff, because that's what I was taught.
Mm-hmm.
Okay, that's what I believed. I didn't think there was anything else to this paradigm. That was it. You know, all this breathing and sleep stuff, it's just do the ENT stuff and they're fixed and they're better for life.
Mm-hmm.
That's what I believed. That's what I continued with until it was a dentist that put something up and it was like, no, this is nonsense. But all right. And it's like, actually, they're right.
Mm-hmm.
I'm wrong. And that was it. That was just like, all right, you just got served basically, Dave. That's what it was. And then from building from there, it's just like, all right, anything new, anything different, anything then that also helps me explain dentistry better.
Mm-hmm.
I can explain, teeth grinding. I was harping on about this in 2013 in Australia, and two people listened to me, and the other thousands told me I was nuts,
Mm-hmm.
and that was okay until others started looking at this, sort of similar thing, but in reverse, and going, look, he might be right. And then all of a sudden, it started to snowball, and now it's pretty standard in Australia. But and look, I'll take the credit for it. I'm the guy that got that ball rolling here in Australia,
Mm-hmm.
and that was way back in 2013, when that sort of resistance to me making this noise in dental circles. And I was the only one making the noise in dental circles because I was the only one that wanted to be in the dental circles.
Yeah.
You know, nobody medically had any interest in being in the dental circles at all. So, changed dentistry there. And, then I get the pushback about the early dental caries. Mouth breathing causes holes in your teeth. Oh, no, it
Yes.
doesn't. Well, funnily enough, yes, it does.
Yeah.
And we still have this mouth breathing orthodontic thing, which to this day just drives me spare, because at the end of the day, it actually doesn't matter. Because at the end of the day, if I look at the pecking order of what does mouth breathing do to a child, well, it affects their brain growth and development. It affects their cardiovascular system. Hey, maybe it affects their jaws. Who knows? Who cares? Did you miss the bit about the brain and the heart?
Mm-hmm.
Before we got to this junction, like
Mm-hmm.
it's just a nonsense argument. It says, mouth breathing does not cause crooked teeth, therefore, mouth breathing doesn't matter. That's the logic, and it's just like, no, 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 no. If you can choose that mouth breathing doesn't matter to you as an orthodontist, that's cool. That's fine. It still matters to that child in terms of their overall health and well-being for everything else that comes with it.
Mm-hmm.
So yeah, so anyway, it's all fun and games, really. So look, I think the more that we talk to each other, the more we learn from each other.
Mm-hmm.
As is often the case with a lot of problems in the world, it's amazing what happens when dialogue rather than animosity actually comes into the room.
Mm-hmm.
Because you actually find that you've actually got a lot more in similar, than you've got in difference. And you can work through those differences, and you can agree to disagree, but you don't need to fight over it.
Right.
And that's
Right.
that's 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 the bit I don't get. There's so much energy is put into fighting, when it just can be like, all right, please help me understand why you think this way.
Mm-hmm.
And if it's at an academic level, it's like, all right, please show me the science and research that you think helps back up what you're sharing,
Mm-hmm.
and we build from there.
Mm-hmm. Wow. I knew this was going to be a great conversation, and I really, really appreciate you taking the time to speak with me. Just one more. If there was something you could say to dentists that, as an ENT, you wish we would do more, or wish you knew, what would it be?
Look, I think the more that you understand that you play a major role in the healthcare system at large, above and beyond teeth, is important. And to do that, you need to engage with the medical community. This is a two-way street. I advocate medical people to, interplay with the dental community, and it's got to go the other way. But you'll
Mm-hmm.
also, again, experience a lot of resistance, and I don't want that to be sort of, a sinking moment of, oh my God, I feel like I'm bashing my head against a brick wall.
Yeah.
um, Find the right people.
Yeah.
Okay. So, if you're looking for an ENT, well, do some heavy lifting, start making some phone calls. Say, look, I just, would like to come and meet with your ENT. I think there's possibility that there could be a lot of interplay between my profession and theirs. Do they already work with dentists? And if they say, yeah, they do, then life got really easy for you.
Mm-hmm.
Um, and they go, no, I'm sorry, I don't think Dr. Smith is going to have time for you today. Cool. Put the phone down, make the next call.
Mm-hmm.
Because if they're not receptive, you're not going to change them. But if
Right.
they're already on board, then you've really found yourself a really valuable asset in terms of what you can deliver healthcare wise. Because then you make it easy for your parents too, because you can go, look, and just so you're welcome to choice, however it wants to work. But this ENT, even though they're on the other side of town, they work really well with this condition, more than anyone else that I'm familiar with. So just want to give you their name so you've got that as a reference.
Mm-hmm.
And it all just builds from there. And the benefit to all this is these kids start getting better,
Yeah, kids are healthier, and they have a chance, an opportunity to grow into healthier adults.
reach their full potential.
Yeah. So thank you again. And it's early in the morning over there, right? You got to go to oh no, it's the weekend though, right?
I got the weekend, so I got the beginning of my weekend now.
Okay, well, thank you again, and I really enjoyed our conversation, and I hope to speak with you again sometime.
Been a real pleasure. Thank you.